Hi, good evening, everyone, and thank you so much for joining us this evening. I'm Adina Blaustein. I'm a Yoatzar Halacha, joining you from just right outside Cleveland, Ohio, and I'm honored to be joined this evening for a conversation with Dr. Nady Fox. Nady is an OBGYN joining us from New York City who specializes in maternal fetal medicine, and he is the host of the Healthful Woman podcast. And Mrs. Riva Judas. Riva is the founder and executive director of Nechama Comfort, an organization that supports families dealing with infant and pregnancy loss. She's a certified chaplain and infant pregnancy loss facilitator. And Dr. Amy Barron. Amy is founder and executive director of I Was Supposed to Have a Baby, a nonprofit that utilizes social media to provide support for those struggling to have a child, and formerly attending pediatrician at the newborn nursery and neonatal intensive care unit at St. Luke's Roosevelt Hospital. Thank you all for joining me tonight. To you all out there, you are probably all aware of this very sobering fact, which is about 10 to 20% of all known pregnancies end in miscarriage. And I open with this to emphasize how from a purely statistical perspective, you or someone you know has, is, or will struggle with this reality at some point in their life. And while the four of us could sit here wishing that we were assigned by the Nishmat Health and Halacha conference organizers for a somewhat cheerier topic, I'm very grateful to be here with you today because I view talks like this as opportunities, even inspiring, because with more information about the halachic and medical and psychological aspects of these issues, we are able to actively create supportive communities and become stronger and more supportive and more knowledgeable advocates. What I'd like to do over the next hour is discuss two cases, variations of which are sadly all too common, variations of which the four of us have gotten lots of questions over the course of our professional careers. And we're going to respond from the medical and psychological and halachic perspectives, not as representatives of specific organizations or medical practices, but as knowledgeable individuals responding as if a woman or a couple reached out to us for advice, for support. And I encourage those of you in the audience to please utilize either the questions and answers option, and that will send a question directly to us. And you can specify in your question which one of us you are directing the question to, or by utilizing the room chat where the questions will go to us as a group. And throughout the questions and answers, I'll be doing my best to scan the chat and then relay the questions to the four of us. I'd like to jump in with our first scenario. And here is the case. A woman is writing in, I went to my doctor, I'm early in my pregnancy, and I was just told there is no fetal heartbeat. The doctor told me that I have some options. I can miscarry naturally. I can take some pills to induce miscarriage, or I can have a DNC. What should I choose? What should I expect from these options from a halachic perspective? Obviously, I want to present this case and anything we speak about this evening that by no means are we offering specific and tailored medical advice. Each case is so specific. Obviously, each woman has to be closely in touch with a doctor. These are purposefully very, very broad cases. Dr. Fox, I'd like to turn to you. And I think when we first start approaching these cases, what's really important is to define some of these medical terms. From a medical perspective, what does a miscarriage mean?
Yeah, thanks, Adina. Interestingly, miscarriage is not even a medical term. We don't use it in our sort of literature because it really was sort of a lay term to when someone lost a pregnancy. And for some, there's a lot of different definitions exactly what that means. I mean, the simplest is pregnancy loss, I would say. The medical terms that you may hear, we use the word spontaneous abortion. The word abortion in medicine does not have the same connotation as it does sort of socially. So a spontaneous abortion is when it's essentially what people think of as a miscarriage, that there's a pregnancy that's developing and then it stops and then it passes. Then there's something called a missed abortion, where essentially the pregnancy stops developing, but it's still inside. And those are probably the most common two that we would see early in pregnancy, like the case you described. In the case you described, since she's pregnant and there's something on ultrasound, but there's no heartbeat, We would refer to that as a missed abortion, but it's essentially a pregnancy loss because obviously the pregnancy is not developing any further, but it's still inside her body. She hasn't passed it yet.
Mm-hmm. I've also heard some other terms. Maybe you can briefly share a little bit about a blighted ovum or a chemical pregnancy. Can you clarify what happens in those scenarios?
So a blighted ovum essentially is it's a form of a missed abortion where there's no embryo inside. It's like an empty sac.
Mm-hmm.
And it's not, again, it is used medically, but it's sort of an older term that doesn't really connote anything specific other than it's a very early missed abortion. A chemical pregnancy is essentially when someone gets pregnant and then they miscarry, but the only way they knew they were pregnant is from either a positive urine pregnancy test or a positive blood chemistry test, meaning someone misses her period. 3 days later, she has a positive pregnancy test. Maybe she takes a blood test and it's positive also. And then a week later, she starts bleeding. And so we know it's not that her period is coming a week or a week and a half late physiologically, but in fact, there was a pregnancy and now it's a loss. And so we called it a chemical pregnancy to indicate we never really saw it on ultrasound or anything like that.
Yeah. And obviously women are testing, you're using pregnancy tests so much earlier and they're so much more accurate. So this would probably be something that could happen much more frequently these days.
Yeah, there's actually really old studies on this where they would ask whole large groups of women who are trying to get pregnant to do a pregnancy test essentially every day. And what was found is that if you include pregnancies where there's a positive pregnancy test and then there isn't a positive pregnancy test, 50% are going to miscarry, meaning there's a very high chance that someone is pregnant just for a very short amount of time and then miscarries, what we call a chemical pregnancy. But a lot of the times they go unnoticed because someone just said, oh, my period was a few days late this month. And again, it doesn't mean she was pregnant, but we found that there's a lot of instances where she is pregnant or was pregnant.
So back to this scenario, in this case, we're assuming that the doctor is giving the woman some options. Can you explain why a doctor might advise one option over the other? And what information would you want to make sure that the woman has for this situation and perhaps even for the future and considering her future fertility?
Right. So, unfortunately, this scenario happens a lot where someone is pregnant and then they realize based on an ultrasound, usually by an ultrasound, that the pregnancy is no longer what we call viable, meaning that it's not going to progress anymore. That either was a heartbeat and it stopped or there never was a heartbeat. And it's inside of her. And there's really 3 ways you can go with this. One option is essentially just to wait. And over some period of time, her body will naturally expel the pregnancy, what we think of as a miscarriage, cramping and bleeding, and the pregnancy passes. And so that's one option. It's perfectly safe. The issue with that is that it's sort of unpredictable. You don't know when it's going to happen. It could be in 2 days. It could be in 2 weeks. It could be in a month or 2. And for many women, that's a very distressing situation to be in, to sort of be walking about the earth, knowing that there's a pregnancy inside of them that's no longer living. And that could be very painful for many women. So for many, that's not a great option. On the other hand, there's no sort of medical intervention, which is what a lot of women prefer. So there's a plus and a minus to that. On the other end is a procedure called a D&C, which is essentially, it is the same procedure as an abortion, but obviously it's not an abortion because this is not a viable pregnancy. We're essentially under some form of anesthesia, whether it's some sort of small anesthesia in someone's office or more significant anesthesia in an operating room. We put a little straw inside the uterus and remove what's left of the pregnancy. Again, the advantage to that is it can be done very quickly. It can be done sort of the same day, the next day, within a few days. And the disadvantage is it requires a procedure, anesthesia. There's some risk, but very little. The third option is taking medication to sort of expedite the natural miscarriage, which is fairly effective in terms of making it quicker. But again, sometimes it's not quite predictable and it may happen at home. There isn't usually a reason why one is preferable to another medically. Occasionally there might be in unique circumstances, but usually all 3 are options. And it almost always ends up being a decision that should be left to this particular person. How does she want this to play out? And obviously no one wants any of this. I always say all the options are bad because this is not a good situation, but which one is the least bad of all of them for her? And frequently that's a personality decision. People who, hear this news and just want this done yesterday and want to start over, then they typically choose the procedure. Sometimes they'll choose the medication, and if it doesn't work, they'll do the procedure. Whereas women who are much more reticent to have procedures done, they just don't want it, they don't like it, they don't like the idea of it, they'll either take the medicine or they'll wait, and usually that's fine.
Mm-hmm. I'd like to speak for a minute about, from a halachic perspective, some of the ramifications of these different procedures or of miscarrying naturally. So just one important consideration, the Torah does prescribe a state of tumah for a woman when she gives birth, with no differentiation made if a woman were to give birth to a live baby or to a stillborn or miscarry. And this state of tumah basically demands that after giving birth to a female, she would wait at least a minimum of 14 days before going to mikveh and being intimate with her husband for a female, and 7 days for a male. However, from a halachic perspective, I think it's important to note that halacha regards pregnancy before 40 days as being incredibly fragile and uncertain. And so the state of biblically prescribed tumah would not apply if a woman is less than 40 days pregnant. And most agree that we would measure 40 days from the woman's most recent visit to the mikveh after a period. So in cases of very early miscarriage, it's very likely that this biblically prescribed state of tumah would not apply. In cases where a woman is more than 40 days pregnant, about 6 weeks or so, what we would basically say is that she doesn't know if she was carrying a male or a female baby, which often she doesn't in cases of somewhat early miscarriage. We would say that she should count a minimum of 14 days from the onset of her bleeding. So either that means from the onset of the miscarriage beginning naturally, or the onset of bleeding from the pills, or the date of the D&C. And she would count 5 days, from the onset of the bleeding, and then 7 days for Shiva Nekiyim. And at some point, just an additional 2 days to count for the 14 days. So either that could be, maybe she waits an additional 2 days before beginning the Shiva Nekiyim. That doesn't really matter as long as she waits a minimum of 14 days from the onset. I think it's important to note, I think there's a difference in how doctors measure gestational age and versus the last mikveh visit. And so it's very easy to get confused with the 40 days. That's why I think it's important from a halachic perspective to keep in mind the last mikveh visit versus what your chart's going to say, what your doctor's going to tell you about how many weeks pregnant you are. And then I think another thing I just want to emphasize, which is the same leniencies that we might apply for spotting and flow would apply here. So sometimes the woman might know that she's expecting a miscarriage and might begin to spot, or even before she goes into a procedure, she's having a planned procedure, but she would apply those same leniencies of, is this spotting or is this a flow, that I would regularly talk to women about when they're expecting a period as well, or when they have an IUD. And this obviously is a very difficult thing to go through. And often that first mikveh visit after this procedure can be fraught, can be very emotional. So I think this is a good opportunity to turn to you, Amy. And I know women often reach out to you with their personal experiences and their personal stories. If this woman reached out to you for support, how would you provide her with support and encouragement, I think, for processing this experience?
Look, I think that, the main thing that happens when someone gets pregnant, and especially, when people reach out to me, often it's when they've often had difficulty getting pregnant. So there's an infertility story that's coupled with the loss story. So when you take those pieces together, this is a pregnancy, regardless of how many weeks gestation it was or how many days you count from the time of mikvah or not. This is a pregnancy that was very, very wanted. And so the moment that someone gets that positive pregnancy test, whether it's a chemical pregnancy or, a number of weeks later, days or weeks later, the reality is that this is a person or this is a couple that is excited. They're hopeful, they're dreaming, they're planning, they're thinking. And so when that pregnancy ends, however they find out, if it's that they start bleeding and then they realize they go to the doctor and there's nothing left on the scan, if they see the numbers going down, or if they just get to the ultrasound, that first ultrasound, and there's nothing there, they're devastated. this was their hopes, this was their dreams, they're planning, they're thinking 9 months ahead. Oh, 9 months is going to be around Pesach time, and it means I have to adjust my schedule like this, and they've already conjured up an entire lifetime of what that means for them and their family when this child gets added to their family. And so it's devastating. It's devastating. And I think the misconception is that when someone has an early pregnancy loss versus if, God forbid, someone has a later pregnancy loss or a stillbirth, as we define in medicine, we define a stillbirth as being a baby that unfortunately dies after 20 weeks gestation, then people say like, oh, well, that was a real baby because that was a bigger baby.
This
That
doesn't
baby
count
was
because
more
it's so
developed.
early.
Exactly. That this one didn't really count. It was just a ball of cells, or you hardly knew you were pregnant, or all of the things that people say, which are so awful and are really like daggers to someone's real, like all of their hopes and dreams. I keep repeating that because it's so important to know. So when people say that they've had a miscarriage or they've had an early loss, don't dismiss their feelings. Don't dismiss the intensity of their emotions. Don't dismiss the attachment, because they are attached and they've been dreaming and planning. And people who don't understand that, and people who just mitigate that and just push it aside and say, why are you still grieving? Why is this still so important to you? Those are the ones that have never been in that position. So my urge to all of you is, don't dismiss people's feelings, because these pregnancies are very real.
Mm-hmm. Yeah. For the woman herself, and I think for the couple, Riva, I'd love to turn to you and ask you to think about, I know from a halachic perspective, there are really very limited halachic requirements with regard to miscarriage. Certainly from around 20, 21 weeks, there would certainly be a halachic requirement for an appropriate burial. But beyond that, halacha really doesn't have many requirements. And in a sense, it is open then. And this, I think, provides an opportunity for the couple to think about how they want to mark that. So what advice or tips would you give to a couple for how to honor those feelings, as Amy was talking about, and process and grieve through this, even in a very early miscarriage?
So I think, we're going to talk about it now, and then the next question too, we'll answer them.
Well, you can expand on it later, maybe just briefly now some tips for this
I just want to
situation.
know that whatever we mention, it's really the most important thing is the couple choice for what they want to do. And as Amy had said, to understand and to respect whatever the couple's wishes are, and to note that the partners, the spouses, may have different wishes, and within the couple, they're going to deal with those differences. But people need to respect and understand their choices. And because we're finding out much earlier that we're pregnant, and the attachment and feeling, as Amy had said, the hopes and the dreams and the pregnancy. So really, the couple is offered the same choices. They can name that baby, because for them, there are medical terms. But if they consider that their pregnancy on their journey, they can give that baby a name that they may only use amongst themselves. They can light the Shabbos candle. They can even be off, if they choose to have some type of ceremony, being an actual burial, and that, again, is personal, that they can discuss with their doctors and their hospitals what's done in that processes. But anything that's offered to them, the guidelines from their hospitals or doctors there's nothing halachically wrong. Or they can, personally, sometimes we encourage something they can plan something that will blossom during that time.
Mm-hmm.
But I can tell you that, we speak to people now who've had these miscarriages maybe 30, 40, 50 years ago. And they can tell you the date of that miscarriage or what holiday was around and what season. So really, they're offered the same choices of how they want to remember that baby and to include that baby into their family.
Mm-hmm. So if I'd like to turn to you, we have a bit more time for this case. If anybody has any other tips or anything they want to add, Dr. Fox, I have a follow-up for you, which is, what advice might you give to this couple regarding future fertility, or what information would you want to make sure that a woman who's having an early miscarriage has as she considers her steps after this miscarriage?
Yeah, I mean, I think there's two things. I think there's the medical side, and then there's also sort of the psychosocial, emotional side. And something that Amy said really struck with me when you're referring, to this as someone's or a couple's hopes and dreams. I found that there's two elements to the grief that comes about. Their first element is what you were talking about, Amy, just this idea that this was their child, this was going to be their child, this was something they were really, someone they were really excited about, and there's a loss. And so there's that sense of grief. And like you said, people have grief in different ways, and it's not for anyone to, judge or examine why someone would or wouldn't grieve a pregnancy different from someone else would. But there's a second component of the grief, which is, why am I not normal? Like, this isn't how it's supposed to go. And I think that that's the reason, in my experience, that a lot of couples have an easier time processing an earlier loss than a later loss. It's not that they have less attachment to the pregnancy necessarily, or less of that first grief. It's just that it's sort of well known that this happens. And so they don't feel like they're aliens. Whereas in a later pregnancy loss, people frequently feel like they're just alone on an island. And I think part of that is helped by conversations like this, where we talk about these and people realize that's not true. All of these terrible, horrible things happen all of the time, unfortunately, to many people. And when people get that sense of community around a loss, that they're not alone, that it's not just them, it doesn't mean there's something wrong with them. I think that there is a way to ameliorate that second part of the grief, that sort of isolation. And I think that actually it ties into the medical part, because almost always when someone has an early pregnancy loss, it's totally just luck, meaning when the egg and the sperm met, the chromosomes are off, and that pregnancy was destined to miscarriage from the start. It's a little bit nihilistic. Some people find that encouraging, some people find that discouraging, but it's just the reality of it. And however, almost everyone who has a loss assumes it was their fault, right? It's because I did this, it's because I didn't do this, I should have done this, I shouldn't have done this. And sometimes that's even messaged to them. And part of the messaging is when we start to really investigate all these things that don't matter. Oh, maybe you did this, maybe you should do this, maybe you should do that. It's just like a backhanded way to blame someone for their miscarriage. And so I try to be very objective with the medical workup to say, okay, there are a few things that are associated with miscarriage. Let's look for those things particularly, because if you were to have them, like, that's unfortunate, but maybe we could do something about it. And all the other ones, like, just drop because they have nothing to do with it. And I think it helps people feel that this wasn't their fault. It happened to them, not that they did something.
And that could be helpful to the couple to move on and to plan for the future and to think about their future options. I'd like to now turn to our second case, equally heartbreaking and also, unfortunately, not as common, but still quite common. And in this case, a woman describes herself as 32 weeks pregnant. My husband and I were just told that there's no heartbeat. My doctor told me I should come back in a few days to deliver the stillborn baby. Are we supposed to sit Shiva? What is delivery going to be like in this situation? Is it going to be done immediately? Am I going to get an epidural? Are we allowed to hold the baby? Are we supposed to bury the baby? So, Nadia, I'd like to once again begin with you to discuss what should this woman in this incredibly heartbreaking and tragic scenario, what should she expect regarding the delivery in this situation?
I mean, it's a disaster. I mean, the whole situation is just awful. It's the worst news they may ever hear in their entire life. Obviously, it's just everything, and there's very little that actually they're going to remember or process from that moment. And so we try to keep it very simple, just to explain what happened, what we know, and just express how sorry we are, and again, try to reassure her that it wasn't her fault that this happened. And there's very little else that's going to happen in that initial conversation. Unfortunately, this situation does happen more common than people think. It's, the rate's about 1 in 500 pregnancies, which seems rare, but that's not rare. That's pretty common, unfortunately. And then over time, and that time might be minutes, it might be hours, it might be days, the couple can decide how they want to proceed. There's rarely an emergent reason to do a delivery. Obviously, a lot of women want to do it as soon as possible if it's very, stressful or upsetting to be in that situation, and that's fine. It can be done sort of rather quickly, but a lot of people need time to process and to think and to talk to people and to plan. And there's also logistics involved. They have other children at home, whatever it might be. And so we really give them the option in terms of timing. And at that point in pregnancy, it's almost always going to be an induction of labor, which is it's not difficult medically. It's actually pretty straightforward medically, fortunately, but it's very difficult emotionally because it's done on a labor floor where women are having babies. And
so she would be given like Pitocin or something like that to induce labor?
The induction of labor is almost exactly the same if there's a stillbirth versus a live baby. There's some subtle differences in terms of dosing of medications, but really it's basically the same. And her experience will be physically the same. Obviously, emotionally be much different. But we try to sort of reassure them that they're not going to be in physical pain. They can get epidurals. They can get even more than epidurals. They can get morphine. They can get Valium. I mean, there's nothing, preventing us from essentially, making them sleepy. And some people do want to remember it. Some people don't want to remember it. I mean, there's obviously a lot of variation here. But also the staff is very aware, labor and delivery floors that are busy, unfortunately, experience this a lot. And so the staff tends to be very well-trained and unfortunately experienced in these situations and know what things she's going to need that are different and how to sort of avoid, the mishap of someone coming in and assuming it's a happy moment when in fact a very sad moment. And, they put various markers on the doors. There's ways that they do this, but ultimately, medically she's going to be okay. But emotionally, this is a very devastating loss that takes a long time, unfortunately, to process. And you never fully recover, obviously. You just sort of improve steadily over time, over the years, I would say.
Are there any, common threads in some of the causes for these very late miscarriages?
It's interesting. There's a lot of data on this, and most of the time we don't find out why it happened for two reasons. Number one, because in order to really find out what happened, you have to do a full investigation, which includes an autopsy of the baby. And a lot of parents are very uncomfortable with that idea, understandably. And so without an autopsy, there's other tests. You examine the placenta, certain blood tests and whatever, but without that, you're frequently not going to know the answer. But even with the autopsy and all the testing, close to 50% of the time, maybe 30% of the time, we're not going to have an answer. Sometimes people say, oh, it was because the cord was around the neck. And it could be a cause that the cord is around the neck. But 1 in 5 babies has a cord around the neck. So anytime there's a stillbirth, 1 in 5 of them will have a cord around the neck at least. And so it doesn't mean it was the cause of the stillbirth. We don't know necessarily. And so that's also challenging. Sometimes we can find a cause, and some of those causes are things that would recur and are preventable, but most of the time they're sporadic, no matter what the cause. Usually they're not things that would happen again.
Mm-hmm. So Riva, I think it's really important to turn to you at this point. I know that Nechama Comfort just so much important work in the tri-state area. If someone reached out to you across the country from Cleveland, right, what advice would you give to this woman, to this couple, for how to mark the loss, to grieve the loss, and to move through it, not past it?
So unfortunately, the numbers are rising, but fortunately, people are feeling more comfortable to speak about it. As Nady had said, the community is so important. So we're speaking to people all over the world now. And it's really the same advice and logistics. First of all, again, going back to the couple's choices, that when we get a call, um, because they do have time to process it, which is good, we're able to speak to the couple, offering them the choices, um, and just reiterating the choices that are given to by the doctor.
Just to clarify, you mean the couple has time because very often they're told there's no heartbeat, but the induction isn't for a little bit.
Right. Or even when if they go in, I mean, I just see that as a job, but I see that more cases are being found out and then scheduled to come in tomorrow. Or even if it's, it's not 1, 2, 3, they still have time, even if it's a few hours, to reach out to find out what is okay. And really, because many Rebbeim and across the board have spent time because they know the importance trying to find out what is allowed and what isn't allowed. Really, they can do their choice. Any choices the hospital's giving to them, they can do. For example, an autopsy, holding the baby, taking pictures of the baby, and not just we want to focus on the women, but also the men. Grandparents are being, barring the COVID rules, but encouraged to come in also to get to see the baby.
In other words, to make this a family grief, a family experience.
Event. There are hospitals, depending on where you are in the country, they have these warming cots now, cold cots, certain cots that the babies can actually stay with them in the room for 24 hours. There are many different options that the different hospitals and doctors are, and what we're trying to tell them is you can accept whatever's going to be comforting to you. What we do try to encourage them is to hold the baby, and to if they want, they can kiss the baby. We also train medical personnel because they're great in the hospitals and they know that Jewish patients they can't touch somebody that's an adult or an older child who has passed away, but we do training that they can be offered this. And if at that point...
Right. I think it's just a good point just to remind our audience that from a halachic perspective, while the requirement for a Jewish burial for kavura would certainly apply in these late miscarriage situations, these late-term losses, the requirements for shiva and for everything that comes along with the halachic kind of a description or definition of avelut would only apply for a loss when the baby it was alive and was full term and more than 30 days old.
Right.
And so while the requirement for kavura would certainly apply in this situation, because halacha is not dictating things like avelut, things like saying yisker, things like aninut, in this situation, this actually is a situation where the couple has these choices, as Riva is saying, to choose how they want to process it.
Right, which is also important to remember that they have the right and the choice to know where the baby is buried, even if they choose not to go to the burial. It's important for the rabbi, the yotzed, who's ever being in touch with, to contact the funeral homes. Most of the funeral homes know how to proceed. Usually, we encourage somebody from the family to go to the funeral, to the burial. They have a choice. Do they want to have a full speeches, talking, the rabbi, or not? Again, it's their choices. We encourage them to choose the name, whatever that may be. And we talk to them again individually on what that means. And if they choose not to go, to have somebody have the record of where the baby is buried, because more times than not, this will help the journey. It's a journey. It's not, there's no set timeline. It takes time, as we had said, as I had discussed, to put it into their lives and move through it. And that's why it's important to have these rituals, these things that are given to them to be able to spend time to the babies. People hearing this may take a second look and think, but the way that the pictures are taken of the baby are a beautiful thing to these couples. Mm-hmm. And again, you can reach out for more individual, but to create what's going to work for you, as you had mentioned, if you want to say yisker, if you want to say kaddish, how you're going to commemorate the yahrzeit, the birth, whatever that's going to work with you. You can do anything that you so choose, and it could be a time that the spouses may differ, as long as there's communication and respect for each other. And I think that's an important point. Most hospitals give you a memory box, which should be taken home. If the couple doesn't feel ready, somebody else should be taken home. And I always say there should be a point person, someone who's with the couple, guiding them and encouraging them, not forcing them. And for grandparents and family members and community members to respect their choices. And there could be not an official Shiva, but there could be a time for mourning and grief.
Sure. And I've even seen a beautiful phrase. Actually, this was on the Nishmat website, suggesting that a phrase of comfort to be offered is Min hashamayim tenachamenu, from heaven may you be comforted, which is just a beautiful way to acknowledge the loss and also, mark that I think when you're sitting Shiva, you're forced into this communal mourning, and the couple might miss that, or feel like that was a part of getting over the grief, but also be grateful that they're not thrust into that. I'm sure you can, I think, understand even more that conflict.
That when it happened to us, that's a person, because you don't understand what's going on, and that we want communities to
Sure.
envelop us, to do all the same things that they're doing, the meals and the food and whatever, reaching out, and to advise people less is more. Nobody's going to be able to fix this.
Sure. On that note, I want to now turn to Amy. How do we help the couple heal after this?
Yeah. It's the unanswerable question. How do we help the couple heal? The answer is you can't, because the couple themselves have to. Well, I just want to make sure. Can you hear me?
Yes.
Okay. Because the couple themselves need to be able to go through their own grief process by themselves. No one can tell them how to do it. No one can tell them what to do. It is something that they're going to have to travel down that road, as Riva was speaking about. They're going to have to travel down that road themselves and figure out for themselves what works for them. So I'll give you a couple of examples. Some people, whether it's an early loss or a late loss, like we're talking about in this scenario, some people really need the time to be able to process on their own. They need that space themselves. They want to hunker down. They don't want to get out of bed. They're not ready to deal with community, not ready to answer the phones, not ready to answer texts. They don't even want to see people who drop off the meals. They want the meals to be dropped at their doors, and they don't want to interact with anyone. And it really takes them time to be able to start to interact with the rest of the community again, and sometimes even the rest of their family. And that is what they need to do, and it's normal for them. There are other people who want to basically try to get back to some semblance of normalcy as fast as possible, because for them, sitting and thinking about their grief and thinking about their baby who they so desperately wanted 24/7 is not helpful for them in a psychological way. It's not helpful for them for any way. They can't bear to think about it so much. And so do they spend their time? Do they have therapy? Do they have the people that they can, process with? Absolutely. But they're going back to work pretty quickly. They're back in shul pretty quickly. They're going back to events and communities. They're going into the grocery store and the supermarket, and their grocery store is the same thing as the supermarket, grocery store and Target. And they're doing all of the things because they want to desperately try to hold on to something that makes them feel normal again. Because every time they look down at their body and every time they think, it reminds them of their baby. And both of those scenarios, and also everything in between, because obviously I'm giving you the very black and white, the here and the here. Mm-hmm. So there are lots of shades of gray here as well. The bottom line is everybody does this differently, and there is no right and there is no wrong way to do it. So I want to really urge people to respect people where they are and to just to hold them and ask them what they need. Because for the one person who says, I need you to take me out, I need to go to Starbucks, I want to go out to the movies, I want you to take me to a concert, let them and go with them. And for the other person, if you even offer to take them out, they might bite your head off. They may not return your calls. They may never talk to you again. You have to ask people what they need and what they want. So that's the first thing I really want to urge everyone out there who's listening, who isn't experiencing this, and thank God has never experienced something like this themselves. Ask people what they need. So that's the first thing. Second thing is, this is something, when someone goes through a loss, this is something that is happening physically to someone's body, to a woman's body. And so what that means is she was pregnant and her body is going through all of those hormonal and physical changes because she was carrying a baby. And in this case, a full-term baby. And now she's not carrying that baby anymore. And that baby is not alive. But her body doesn't know the baby is not alive. The body just thinks she had a baby. And so these women, they make milk. These women are still having uterine contractions. Their uterus has to get back to that normal size. Many of these women look pregnant because for weeks and months afterwards, because they gained all of the pregnancy weight that they needed to do in order to sustain a healthy pregnancy. But the weight, unlike, the celebrities we see on TV, the weight
not just going to come off. Yeah.
Correct. It doesn't just fall off. And so for these women, every single day when they get up in the morning, if they don't remember their baby immediately when they wake up, they're remembering their baby because their clothes don't fit them properly, or because they're just looking down at their body and saying, what on earth happened and why is my body not snapping back to normal? And then it also means that for that person who's out in the grocery store and out at Starbucks, they still look pregnant. And so people will comment because people are silly and people are stupid. And because you're not walking around with a sign across your chest saying, I had a stillbirth. So people who know you, or maybe people who don't know you, will say, so when is the baby due? And I always talk to these families, to these women and the families, and say to them, you have to have a response ready because people will ask. And you have to be in a position to be able to respond and not break down in the middle of Target. And because, you had to go there to get some errands.
You have to live your life.
Correct. You have to live your life.
So what could be a response someone could say?
Right. So I think it depends on your emotional bandwidth. It depends at the time. It depends on whether that person who's asking you, whether it's someone that you have a relationship with, or whether it's someone that you do not have a relationship with. So people who you don't have a relationship with, who you're never going to see again, right? The checkout person at Target, that we're using this as the example, who says, oh, when is the baby due? You can be very flippant and you can be very direct and say, my baby died, period. And that immediately makes people go quiet. You can, if you have enough emotional bandwidth, you can also say, it's not really appropriate to be commenting on people's bodies because you don't know when someone's pregnant or when someone, God forbid, had a loss like me. And then you're teaching someone a lesson. But it takes someone a tremendous amount of emotional fortitude to be able to do that. And also time, because the reality is that none of us are going to Target and just, relaxing as we're running our errands. It's often we want to get in and out. And we often don't have the time to do that, let alone the emotional bandwidth. So that's if it's someone you don't know and you don't care about what they think of you afterwards. You don't care. You can have that flippant, sarcastic response because you're never going to see them again. For the people who you are going to see again, or for the people who you do have a relationship with. So what we advise is to kind of circumvent even having that kind of conversation is when you have God forbid, when you are going through this and when you have a stillbirth, to appoint someone in your family, whether it's your husband or someone else who's close to you in your family, to get the word out to your community. Let the community know, let your friends know, let the extended family know, so that hopefully these kinds of interactions won't happen. Because unfortunately, everybody loves good gossip. And so if you send one person out, so to speak, to spread this message around, the message will go and then people will know not to say something. But if it is that person who just didn't get the message, then you just have to decide and say, I think, the truth is always, I always say, and we always say that the truth is always the best way to answer these kinds of questions. Just the baby died. And then immediately the person realizes that, again, maybe they should not have asked, and that hopefully they pause and will not ask those kinds of questions again. I mean, look, these questions are common. People get these questions a lot, is, not even in these scenarios, but anyone who carries weight around their stomach, people are constantly asking them about whether they're pregnant or when the baby is due. And then, there's a whole other set of responses that we give. But specifically in this scenario, when people ask you that, it just feels like they're speaking directly to your heartbreak. And it's so, so hard. So make sure you have the room and the time afterwards to go to your car and cry, because I did it so many times myself.
Well, thank you. Obviously, we've been centering, I think for good reason, a lot of our responses surrounding how the woman's going to heal. Certainly these comments about her body, the woman is going to be on the receiving end. She's going to have to be the one to come up with these very brave responses, very heroic responses. But I know in all of your work, often you're dealing with a couple, and how the man and how the woman may process this might be different. So I want to turn to you and ask you, how through your work have you found men and women might be surprising or different in their responses? And how then does that translate in how we can build supportive communities that help support, both men and women, obviously, through these kinds of losses? So this is an open question to our panelists.
I think that it's so important to remember men and women. And what I found over the years is maybe men are, more into their feelings or given permission to express their feelings. It's not the typical, the way a man is, the way a woman is. It's really individual. How they react to the loss depends on so many factors: how they were raised, what other traumas have gone on in their lives, who they are as people. And I think that's important to remember and to focus in on the couple. That's why they need this support. And for the communities, which I've seen a much better job, especially because the talk has been there, not to forget the men, not to forget that there's a component, especially within our communities, of social obligations, religious obligations, individually, what is happening to their faith. So if somebody is showing up at shul, if somebody isn't, making sure the rabbi, the people in the community are reaching out to them too. And just remember to saying simple words, how's everything? And to really, keep on that track. Less is more, as we always say, that, we have a list, of our do's and don'ts. And it's really just showing that you care. Another point, the first month or two, everybody's reaching out. And this is a general issue when it comes to Avelut and helping comfort people with their loss. Make a note, even on your calendar or your phone. Reach out to the couple individually and together. Couple months later, and I think that's what's important to know, and to know that they have a place, and the grandparents and the other children and the future children.
They're part of a larger network and a larger family
that interact, and that's why we need to work with them individually as well as together.
So I think that the your question about what about the men? The question is a really important one, because the reality is that the men are often forgotten, as you made mention of, and as many of us are making mention of. They have these obligations that Riva talked about. They need to deal with whatever else is going on, taking care of the logistics, going back to work, going back to school, doing many of the things that they have to do, these obligations. And they often don't have time for their grief and have time for their feelings. And so what I found in many, many occasions is that the men sublimate their feelings and just go on with life. And women are the ones that are emotive. They're the ones that are constantly talking about it. And there's this emotional disconnect, frankly, between the couple, of her saying, I don't understand. How are you going about your life while I'm still sitting in bed and I'm grieving and you seem to be fine? And like, did you not care about me? Did you not care about this? There is the constant disconnect. And whether it's because of the society rule, so to speak, about society says that men should not be and do not and may not, or whether it's just because they feel that they need to pick up the pieces because the woman is the one who's really holding most of the burden here. The reality is that often there is that disconnect. And I'll even say on the flip side that there have been many couples that I've worked with, and I know Riva has worked with as well, where it is the man that is grieving much, much, much more intensely than the woman. And so that emotional disconnect can go in both ways. The woman is fine, she's back and she's this, and the man is the one who's depressed and he can't get out of it. And he was the one who had these hopes and dreams, and not that she didn't, but he's the one that's holding on to it in a much stronger way. The most important piece out of all of this is communication. It is making sure that the two of them are talking to each other, making sure that they're expressing their emotions to each other and saying, I feel like you don't hear me. I feel like you don't see me. And he's like, well, what are you talking about? I'm just trying to manage. It's important to get them talking. And if they're still having this sort of butting of the heads and this disconnect, then we always advise that they reach out to outside counsel, whether that's to a trusted rabbi, to a yoset, to a therapist, to a couples therapist, or individual therapy. These are not simple issues. It is very, very common for couples to have relationship issues after dealing with infertility or any kinds of a loss. This is common. It is more common to have it than it is not to have it. And so always seeking outside help, if you can't solve it within yourselves, within the relationship, is always a good idea. Always.
Mm-hmm. And what's good is, I think that in social media, in the world of entertainment, sports, we're seeing a lot of men sharing their stories and couples sharing their stories. The whole idea of tonight's program, the whole program, what Amy does, what I do, is that nobody should ever feel alone. Because not too long ago, there was no support system. There weren't wonderful doctors like Nady that were there, that understood, and that the education also for that have started. We started programs now in high schools, both to boys and girls, and college and colleges and just in the world, that they should understand now that it's okay, that more often than not, it's not going to be, what we learned in preschool, that we're going to all live in the house and grow. And I was a preschool teacher, and grow. And I think that I've seen a big change towards the positive. And I think that's because of all of this helping to get the information out there to the young people beforehand, for them to understand how common it is medically, emotionally, and to never feel alone, and the support is there.
What a beautiful message. I want to close by thanking each of you for participating in this conversation with me and asking you each one final question. I know that each of you does have such a powerful mission beyond supporting an individual woman or an individual couple. And I'd like to ask each of you to speak briefly for 1 minute, because we have some time, but we don't have so much time, about what new understanding are you hoping that we develop in our communities, and what new understanding are you hoping that people begin sharing? So, Nady, Dr. Fox, I'd like to start with you.
Yeah, I mean, I think that what I've learned over the years is much more mental health than medical knowledge. You know, what we know now about miscarriage and loss and fertility, all right, we know more now than we did 10, 15 years ago, but I think there's been such a important awakening as to the critical nature of the mental health components of all this, both going into it and trying to get through it afterwards. And I think that, you know, it's sort of I don't want to say a two-edged sword. I guess I just did. You know, on the one hand, I think that it's so critical that we focus on it and we encourage people to be emotive if they want to be, obviously, and to think about this. But on the other hand, you know, sometimes we're just beating people up in a sense. We keep, you know, like you said, like you give an example for Amy, like, why are you not more depressed? Why are you going out? And I think that it's, you know, mental health is really much more about an individual's response to the world and how are they coping, and not so much how we think they should be coping with something. And it's almost about their function. Are they able to sort of get up out of bed and get through the day and go to sleep at night? And with something like this, if you can do that, it's a win. And I think that, you know, from all of us on the outside, it's more about compassion and empathy and understanding than it is about solutions. We're not going to solve their problems, like you said, Amy.
Thank you. I hate to cut
they're
you off.
grieving no matter what we do. Yeah.
Yeah. Amy.
I think that the secrecy piece of all of this, the shame, the taboo, the isolation that our community and the community at large has felt about pregnancy loss in general, that there is a real seismic shift at this moment where we are now having these discussions. We're sitting here on a panel and talking about pregnancy loss at large. People now are talking about their losses and their miscarriages, even if they never announced their pregnancy because it was too early in their communities to talk about their pregnancy. Mm-hmm. And so the fact that we are now at a space and time where people can discuss this because they know that it's not their fault, as Nady said, and as the community knows, we are in a different space and people are getting the support they need. And for that, I'm incredibly grateful.
Thank you. Riva.
So I'm always amazed when I'm on a program like this and when I get off a program, because we have really come to an amazing place. When my son died 35 years ago, there was not even a thought that this day would come. And that to know that we're helping so many people, being able to take their loss of their children, which they are, like we had said, their children that live in their hopes and dreams, and to have their choice if that's how they want to deal with it, and that of how they can put it into their lives, and to move through it, and that they'll be productive. And it's so important to be true to yourselves, and for the community to open up their arms and respect each other. And you know, the first time that I heard the first Joettes that speak in Teaneck, I remember coming home and saying, "Okay, the world's going to be okay. We're have conversations. We open. We're going to ask questions." And again, I'll repeat it because that's the goal every day when I wake up. Nobody should ever feel alone going through pregnancy and fit loss.
Well, that mission definitely powerfully resonates with me. And I know that Nishmat's mission in general is to create a space for people to ask questions and get good, knowledgeable responses grounded in halakha, grounded in medical and the best psychological advice. So with that, I want to thank you. Thank you, Nady. Thank you, Amy. Thank you, Riva. And to all of you out there, let's build the kinds of supportive communities that we really want to live in for ourselves and for our children, for future generations of Bnei Israel. All the best to you. Have a good night.
Thank you.
Right.